Hello, my name is Dr. Wolfgang Steudel. I am an anesthesiologist and I would like to speak about anesthesia drugs and airway management for this forum. One cannot imagine surgery without anesthesia. It is a fascinating specialty of medicine. In order to perform surgery, 4 important preconditions have to be fulfilled: amnesia, unconsciousness, analgesia, and lack of movement. Medications such as Valium, midazolam, or Versed are benzodiazepines and typical amnesia drugs. After their administration, the patient cannot hold on to memories for a certain period of time. Strong pain-relieving drugs such as fentanyl and morphine are given intravenously for surgery. They are related to Percocet, hydrocodone, and oxycodone. Heroin, a narcotic street drug, has been laced with a much stronger fentanyl in unpredictable mixtures and has caused many deaths in recent years. At the beginning of general anesthesia, an intravenous injection of Propofol, ketamine, or etomidate is given. This leads to deep unconsciousness. After a breathing device has been inserted, inhaled anesthesia gases maintain unconsciousness. Finally, in some cases, the patient may receive a muscle relaxant. This is not a muscle relaxant as used in the treatment of fibromyalgia, muscle spasms, or back pain. These are very strong medications which temporarily but entirely interrupt the connection between nerves and muscles. At the end of surgery, the effect of these muscle relaxants is reversed. Patients often have the perception that anesthesia is deep sleep, but as you can appreciate, anesthesia is actually controlled unconsciousness. Unlike sleep, breathing is suppressed or completely abolished, and only after the drugs have been metabolized by or eliminated from the body will the patient be aroused again. Now I would like to turn my attention specifically to Propofol, which has made a lot of press in recent years. Propofol is a very safe anesthetic. We use it every day as the only anesthetic in procedures such as colonoscopies. There, when given as an infusion, it is just necessary to support the patient's breathing with an oxygen mask. When Propofol is given in a single large dose, it entirely suppresses the breathing, requiring the anesthesiologist to take over. Airway management is a technical term to describe how to establish safe support of breathing after drugs have been given which suppress or abolish breathing after induction of anesthesia. Patients have different face, neck, and body anatomies due to various reasons. They might be born like this. It could be because they lost or gained some weight, or they might have an illness which changes their anatomy. This is very important when we need to manage their breathing. When the anesthesiologist gives the first medication, the induction agent, usually Propofol, he or she supports the patient's breathing with an anesthesia face mask. Depending on the type of surgery, a modified mask or laryngeal mask airway, LMA, might be inserted in the mouth, but is still not considered an absolutely secured airway. For other procedures, especially when complete muscle relaxation is needed, it is necessary to insert a breathing tube or endotracheal tube through the vocal cords. This is the most challenging procedure, especially in patients with difficult anatomy. Many modern devices have been developed to facilitate the placement of an endotracheal tube. Only if the anesthesiologist has made sure that the oxygen levels and the vital signs remain stable between awake state until the appropriate airway device has been inserted can one consider it safe airway management. I like to compare aspects of anesthesia with aviation. Landing in aviation is the most critical part of the flight. In our specialty, the beginning of anesthesia is the most critical part. When we give drugs which impair breathing, we have to make sure that the patient is either breathing sufficiently on their own or that the breathing can be safely supported at any point in time. When the plane approaches the runway, there's a point where the pilot has to make an important decision. Are the conditions safe to land? Is there too much crosswind or headwind? Is the runway free? Do I have clearance from the tower? At this point, the pilot can still interrupt the approach and try another circle and try another approach if necessary. It is called go-around point. Let's take the scenario to anesthesia. Before the beginning of surgery, the anesthesiologist decides to give a large dose of the induction agent, usually Propofol. This causes unconsciousness and a patient stops breathing. If now the support with a breathing mask is difficult and an LMA cannot be easily inserted, or used. There's a problem. Now, like in the plane, the important decision is whether trying to land, giving a muscle laxant and attempting an endotracheal intubation, or to choose a go-around, letting the effects of propofol wear off and let the patient arouse and choose alternatives. A failed landing can be disastrous. As you can appreciate, this requires a careful assessment of the patient's anatomy and the feasibility of safe airway management, similar to being in control of the plane at any point in time. In other cases, it might be necessary to place the endotracheal tube while the patient is still awake and breathing on her own, and only has received some sedatives for the procedure and local anesthesia to suppress the gag and cough reflexes. This awake intubation using a fiber optic camera then allows a safe transition from spontaneous breathing to controlled ventilation without the risk of low oxygen levels at any point in time. This was a short overview over anesthesia drugs and airway management, for which good training is crucial to avoid complications. Airway management is also important for other physicians, as in the ER, ICU and EMT staff who encounter unconscious patients. They are not exposed to airway management every day like anesthesiologists are, and their situations are often much less controlled. One more word on anesthesia drugs. If drugs are given in the operating room or recovery room and they outlast the time of supervision by anesthesiologists or nurses in these areas, and patients have breathing problems or distress outside of these areas, this could present a life-threatening situation, which requires airway management and resuscitation by appropriately trained providers. With this, I would like to end my presentation. I am available as an expert witness and consultant. I evaluate cases which involve unwanted effects of anesthesia drugs, cases with difficult airway management, and related topics. I am also qualified and trained to evaluate cases in anesthesia for obstetrics and anesthesia for most surgical specialties. Please do not hesitate to contact me with your specific inquiries. Thank you very much.